everyone. Today we're talking about ASD, and let's just introduce ourselves first. So this is our host Nelly. Then we also have Jenna and myself, Rebecca here.
And we're doing this talk show for our module Psychological Disorders. And we have a special guest, Miss YY, who is a clinical psychologist in Malaysia. And currently, she's getting her registration done in Australia.
Morning, everyone, and welcome to today's talk show. My name is Nelly, and I promise that I won't stress you out, even if today's topic is acute stress disorder. And now, stress is something that we've all felt, even deadline, exams, or when you're in the middle of Netflix and the Wi-Fi disconnect and you're binging something. But acute stress disorder or ASD is a bit different. It's what can happen after a really traumatic event, and it affects people in deep and powerful ways. So, just a statistic, did you know that 6% and 33% of people who go through trauma and can develop ASD? So, we have a special guest with us today.
Yes, thank you for that, Nelly. A little introduction to myself as well. So I previously have work experiences with Women's Aid Organization in Malaysia. So most of the clientele there have trauma symptoms because we are working with victims of abuse or refugees from war-torn countries, and also work with clientele from MMHA, Malaysian Mental Health Association. And also currently in my line of work, I primarily work with a lot of nurses or individuals with trauma from childhood or even current workplace trauma. Uh, so that's a little bit about me.
Okay, thank you, Miss Kaiwai. So, let's start to the basic. Miss Kaiwai, could you tell us what is acute stress disorder and how can we differentiate it from PTSD?
Acute stress disorder, and in this talk show, I will be using the abbreviation of ASD, but this is not to be confused with other disorders with similar abbreviation. So acute stress disorder is a time limited trauma related disorder. So, it usually occurs between 3 days to 1 month after the individual is exposed to trauma related events. So most of the time, clientels who have acute stress disorder would have symptoms such as intrusive symptoms, dissociation, or avoidance, arousal, or even marked distress or impairment symptoms.
All right, thank you. That makes it much clearer. But now let's start with the big question. What actually causes ASD? Is it our family? Is it our genetics? Or is it even society? So, probably a bit of all right. We'll start with the biological side and think of it like wiring a computer. Okay, so let's dive in. Okay, hi, my name is Rebecca, and I have a few questions regarding the biological factors. So, Ms. YY, I read that the heritability of stress-related disorders can be as high as 70%, although most sources say something between 30 to 50%. And from your experience, do you feel like ASD runs in families?
I have certainly observed that vulnerabilities can come from clusters and families. But that said, I think that it's crucial to consider what we see clinically, as there's a mix of genetic predisposition as well as environmental influences. So, shared trauma exposure, learned coping patterns, and even intergenerational influences can be an impact to a person's risk for getting acute stress disorder. So, in my experience, family history is a meaningful risk, but it is not a determining factor. So there are other things like protective factors, or such as strong family support, or even sorry, not even family support, like social systems. like workplace support or friendships. And adaptive coping style can actually substantially mitigate like inherited vulnerability.
Okay, so you would say it's both like also familiar factors, but also genetics? Yes. Okay, perfect. Also, as a clinical psychologist, do you work with physicians to monitor stress-related hormones, or is that not relevant for therapy?
So I don't directly monitor my clients' stress-related hormones. So that's outside the scope of psychological practice. So instead, what I do is I rely on validated assessment tools and careful clinical interviewing to monitor symptoms and functioning of my clients. So even something as simple as asking like, "How has your day been?" can actually provide a lot of insight into how the trauma symptoms has impacted the person's daily life. So, most likely, this person would have issues with concentration at work, their sleep quality would have been impacted, or they could also be avoidance behavior that would feel more anxiety. So, that said, I do still see value in collaborating with physicians, particularly when clients are prescribed medication or especially in Australia where medical reports are actually needed, um, because like this will assist these uh, these clinicians will also assist the person into returning back to work. So in my experience, because I work especially with healthcare workers who has been traumatized in their line of work, it is actually very important to keep their doctors in the loop. So physicians would manage the biological aspect of trauma, while we as sort of address the psychological and the functional of recovery. And the collaboration actually helps the client to have a bit more of a effective care.
I have a last question. Have you noticed any neurological or physical changes in your patients, like vulnerability to illnesses or like memory problems?
So yes, I certainly observe changes, though they are often a bit more psychological or behavioral than just strictly neurological. So clients frequently would report like disruption in sleep and appetite. That's usually the first to go. And then, which in turn can worsen trauma symptoms like hyperarousal and concentration or difficulties in concentration. So physically, I've also seen changes where there could be like a fluctuation in weight, fatigue, and sometimes neglected self care or grooming. So these can be sort of like a marked indicator of how the stress is impacting their daily life and functionality.
Thank you very much.
Yeah, sorry, I do want to add that even though I don't conduct neurological assessments myself, research does show that trauma can affect brain regions like the amygdala and definitely the hippocampus. So I keep that in mind when I formulate my cases. But in day to day practice, I mostly track observable change. So, sleep, energy, appetite, motivation, because those are more tied directly to recovery and quality of life.
Awesome. Thank you very much for that. And I want to introduce Jenna, who is joining us today.
I have a few questions regarding the psychological factors. So, Ms. Wai, let's talk about trauma itself. So, how does experiencing trauma directly contribute to the development of acute stress disorder?
So, in terms of physiological symptoms, so when we talk about how trauma impacts physiology, there is usually a surge of overwhelming threat response that gets activated. So, that's what we call the fight or flight or freeze response. So, then the amygdala in the brain becomes more hyperactive during fear responses because, again, that's about survival, right? I have to survive this traumatic experience. And then the prefrontal cortex, which normally regulates fear, is often suppressed. So this means that this person would probably have poorer emotional regulation and more intrusive memories would happen. And in terms of memory and dissociation, trauma does impact the hippocampal functioning, which would then impair contextual memory. So it's very common where people don't really exactly remember what happened during the traumatic events. And that's where therapy comes into play, where we are trying to piece together what happened during the trauma to help the client make a meaning behind what happened. And dissociation often also happens hand in hand when traumatic event happens because it emerges as a defense mechanism against the overwhelming emotional intensity. And lastly, the psychological impact is it sort of shatters a person's understanding of what safety and control means in their belief system. So, as a result, sometimes avoidance, hypervigilance, and negative mood would come in a way to sort of try and cope with the trauma's meaning and the reminders of it.
Okay, thank you. So, speaking of trauma, are some traumas like violence compared to accidents more likely to trigger it?
That's a very good question. And I actually have to do a bit of research to make sure that what I'm saying is actually justified rather than it being my clinical experience. But in short, from what I found, yes, certain types of trauma do appear to be more likely to trigger acute stress disorder. So, for example, interpersonal traumas such as assault, sexual violence, or combat. Um, so, those who are in war are more associated with higher rates in trauma or developing acute stress disorder. So, in contrast, like unintentional traumas, like let's say accidents or um, natural disasters, might be lower, but it is still notable rates. Like people still develop trauma after these instances. So, clinically, what that means is that I think that most clients with acute stress disorder, especially after a traumatic event, has actually a lot of difficulty piecing together information that had happened. And when something within the event doesn't make sense to them, like again, this is a belief system shattering. The world is no longer as safe as I think. It violates their understanding of what the world means and how it used to make sense. So this amplifies a lot of fear and dissociation. And so ASD happened. So that say, I do believe that in any traumatic event, be it accidents or violence, any trauma with that overwhelms the coping resources can actually lead to ASD.
Okay, so does it also happen to people who already suffer from anxiety or depression? Does it make them more vulnerable to ASD?
Yes, I would say so. So because there's a baseline of hyperarousal and negative effect, right? But when people already experience anxiety or depression, they usually often already experience heightened stress reactivity. So most likely these people are already having difficulties with sleep and they already have difficulties regulating their emotions. So then after trauma, what happens is that these pre-existing vulnerabilities would just amplify and they would have intrusive thoughts, more hypervigilance, and mood dysregulations just haywire. So then, in terms of like, if you look at cognitive as well, if a person already has cognitive distortions, so they would sort of not really have they would have like heightened catastrophic thoughts. Let's say this would just exacerbate that and cause more rumination. So, yeah, I would say that's the case.
All right, thank you.
Now that we talked about trauma, let's talk about some coping strategies. So, our coping strategies, I mean, it's very interesting. So, what unhealthy coping mechanisms do you often see in your practice? Like maybe avoidance, substance use, or something like that?
Yes, there would be. So there's two lines of thoughts. There's the a more adaptive, healthy coping mechanisms and the unhealthy one. So I think the one that you're pointing out is more so the how do people um, cope with cope unhealthily. So a big one would be avoidance. So avoiding reminders of things that could trigger their trauma. They might stop socializing with people that reminds them of traumatic events. They might avoid places or activities that's associated with a trauma. But what this does is that it leads to reinforcement of fear and anxiety, and it actually prevents the person from actually processing the trauma. So there's also distraction based coping. So a lot of indulgence in video games, watching TVs, surfing the internet, or just working to avoid thinking about trauma. And then substance use is also associated with unhealthy coping. They might engage in alcohol drinking or using recreational drugs to numb feelings.
Right. So, what are some of the healthy coping strategies that you would suggest to your patients?
In terms of healthier coping strategies, would definitely firstly be seeking social support. So, well, the first line would definitely be professional support, because then these are experienced professionals who knows what they're doing, and they have been trained to manage symptoms like these. But even reaching out to trusted friends, families, and more importantly, supportive colleagues or workplace contacts is a very big key indicator of whether this person can go through recovery or not. Um, and the reason why I talk about work is because in my line of work, I work with healthcare workers, and we work very closely in their loop of workplace settings to ensure that they can, even let's say their manager can help manage expectations, and they can access, like the impacted person can access more accommodations, and there's less performance pressure for this person who essentially is going through injury. And then another thing is self care and physical health. So making sure that they have, as much as they might have a change in appetite, making sure that they have standardized food and nutrition, rest, sleep to sort of stabilize their mood and energy. So another big thing is that a lot of my clients find helpful is having a routine and structure, because when once chaos is introduced, daily routine actually helps provide that sense of safety and predictability, to help with their cognitive recovery. And then there's also self compassion, acceptance. Um, a lot of the times when you talk to patients who have gone through traumatic events, they tend to be extra hard on themselves, especially during recovery period. Like, why am I not performing as I did prior to injury? And then that's the time where you actually have to intervene and talk about like what recovery actually looks like, and normalize certain symptoms so that they can also translate that to internal self-compassionate talk.
All right.
Yeah,
Thank
so
you.
there are a few.
Okay, thank you so much for your answers. And now I'll pass the mic to Nelly. Rebecca. Okay, Rebecca.
Okay, so thank you very much, Jenna. And now I want to talk about family, because the way family and friends react can also have a huge impact. So, Ms. YY, how does family support have an impact on someone coping with ASD?
So, in terms of how families, okay, it could be a double-edged sword here, because families sometimes they can serve as a protective factor, but sometimes they can actually serve as a negative, it can have a negative impact to the patients. If, let's say, they don't have a supportive family or it's a dysfunctional family. So let's talk about the positive one first. So, um, a, a protective factor for families that are functional can allow this person to have emotional validation. They can actually offer practical assistance. For example, um, some of my clients, after traumatic event, they can't take care of themselves. Most likely their bedroom looks like a mess, but if family understands what they're going through, they can actually provide practical assistance, like, I'm going to help you clean your room, I'm going to make sure that you have regular meals each day. So it can also provide a sense of safety for this person. Like, this is someone familiar, and I feel safe, at least in my home. So it can help with adaptive coping. But when families that are not really supportive or it's dysfunctional, it can lead to more criticisms, and it can invalidate the person's experience, which can exacerbate more symptoms. So it can increase more avoidance, more anxiety, more depressive reactions. And sometimes some families might also reinforce certain maladaptive coping, like substance use and alcohol, drugs, or create like isolating environment for these individuals. So yeah, that's my stance.
So quite mixed there. Then I want to go on to stigma because in some cultures people are told to be strong or hide their symptoms. So does this cultural stigma prevent people from seeking help?
Yes, I think if you're talking about in Malaysia, where collectivism is prevalent, mental health issues are not only just trauma, but I think just mental health issue as a whole are often perceived as a threat to, let's say, family honor or social reputation. So this perspective can actually lead to individuals concealing their distress and avoid going or seeking professional help to avoid bringing shame to the family. And there's also, I think there's a study that is done by Utah that looks at public mental health stigma and low mental health literacy. And it's associated a lot with help seeking behavior. So there will be a lack of help seeking behaviors uh, because of that. So many individuals may not even recognize symptoms of acute stress disorder, or they might even attribute them to weakness and leading to delay in appropriate care. Um, yeah, so that's pretty much it.
So do you feel like cultural beliefs are adding up to that because people may believe it is fate or punishment that they are that they receive?
In terms of cultural explanations of trauma, um, yes, sometimes I've heard of people viewing it as fate, punishment, or spiritual imbalance. Um, and it can actually help people, it actually shapes how these people understand or interpret their symptoms. For some, it provides like a sense of meaning, but what it does is that internalizes the distress, and it's seen as, oh, I morally deserve this bad things happening to me, which can lead to more passivity and reduce in help seeking. So that's the shame, right? Like it, I deserve this happened to me, I deserve it. So it actually distracts them from getting proper psychological support. Um, and sometimes, like in certain cultural norms, if let's say it leads to sort of minimizing or it normalizes distress, um, people are unlikely or less likely to seek help and treatment until it's catastrophic. So, clinically, being aware of this cultural interpretations is actually very important in terms of ensuring that clients have sensitive care so that they can integrate like meaningful approach alongside evidence-based interventions.
Now for my last question for this day. Do you feel like gender roles affect how males and females seek help?
Definitely. So I think even in studies it shows that. So many cultures, but even in Malaysia, masculinity norms emphasizes on self-reliance, emotional control. So most likely male patients tend to underreport symptoms. They might even altogether avoid seeking help, and they might cope through other means like work or substance use, whereas females tend to be a bit more sociable. They can emotionally express a bit more, and they're relationally oriented, so they would have social support. But they tend to also experience heightened self-blame or guilt. So in terms of coping, how these two genders differ in coping is that men, and this is a generalization based on research, right? Men tend to be a bit more problem focused when they cope. So they would avoid rather than talk about trauma. Women may engage in more social support and emotion focused coping, but sometimes it also intensifies ruminative thinking. So if you look at help seeking behavior, men would tend to be a bit more, it may be a bit more delayed because they don't want to appear weak. Women may seek help a bit sooner, but they still face similar stigma due to societal expectation. Like in terms of women, the gender roles, like they tend to be like a caregiving role, family responsibility. So they're less likely to seek. They're they are more stigmatized in that way. So in terms of that, that's how I see the differences in gender when it comes to talking about trauma and help seeking behavior.
Thank you very much for your insights. And now I want to come back to our host. Okay, so we've talked about ASD, what causes it, and what are the different factors that influence this type of disorder. But now we come to the hopeful part. What can we do about it? So, Miss YY, could you tell us what treatment option exists and what are the type of interventions?
Mm. So if we're talking about clinical care, um, well, socially, a person can do a lot. Actually, let's start with that. Socially, after recognizing symptoms of trauma, firstly, to understand that this is a normal reaction after a traumatic event. So to empower yourself with a bit more knowledge, read up about what's going on, what is considered normal in an abnormal circumstance, um, and also seek social support, friends, family, trusted people, because again, it's all about creating a sense of safety and normalcy. And then after that, if let's say you are still experiencing a lot of trauma symptoms, um, the earliest intervention would be to seek professional support. So trauma focused CBT seem to have a lot of is evidence based. I also use things called crisis intervention stress management. So we use different skills to sort of address um, uh, a client's symptoms to understand actually in their psyche what has gone differently, what is the things that are beyond their expectations, and how do we address that. So cognitive restructuring is probably what we do, and also exposure. Clients have to learn or they have to relearn that the environment that they were previously in is an abnormal circumstance, but generally they have to relearn that this is not something to be feared. So an example that I had is working with a nurse who previously was had met with a violent patient, and she started avoiding certain rooms in the hospital or even lifts. So her having to go through exposure therapy is going back to the lift and relearning that this is an environment that is generally safe, but and that traumatic event is an abnormal circumstance. So of course that takes a lot of um, trust and a lot of sessions to go through that. Yeah.
Thank you, Miss YY. So before we wrap up, let's do a little recap. Acute stress disorder is it can happen to anyone after trauma, so it's not a sign of weakness. It depends on factors also such as social, biological, and also trauma that the person has experienced. And also, most importantly, recovery is possible, right, Miss YY?
Sorry,
Recovery is possible with acute stress disorder and the right support.
Yes, of definitely. Recovery is definitely possible uh, for individuals who has acute stress disorder or even PTSD if it develops to that.
So now we've learned about the science, the brain, and how does the cultural factors affect and lead to acute stress disorder. Now we can move to a lived experience. So we have today with us a role play nurse who has experienced a traumatic event in the hospital, and she will share with us her experiences so that we can understand how acute stress goes.
Okay. So thank you for having me. and I work in the emergency department. So everything was okay with me until one day there was this patient who had got into a car accident, a young man, and then we were short staffed at the time. So for around an hour, I was the only nurse available to attend that patient, and I kind of froze at the moment because it was very shocking for me. I'm supposed to protect the patient, but the patient was very violent and he was just lashing out at me. And he even pushed me away. And then at that moment, I didn't know what to do, who to ask for help, because as I mentioned, we were short staffed. And then this went on for about 40 minutes until the doctor arrived and then handled and checked the patient. But yeah, at that time, I didn't realize, but now looking back, it was very traumatic experience for me, and I sometimes feel uncomfortable now if any emergency patient arrives at night, especially if it's a male, and I cannot treat my patients how I used to. I'm not uncomfortable now, and I sometimes have flashbacks about this, and I tried to talk about this with my other colleagues who are nurses, but then they just said it will be okay, it will be all right. But till now, I still face difficulties. Yeah.
Thank you so much for sharing it and for giving us an insight of how acute stress works.
You're welcome.
Thank you. So thank you so much for your insight, and thank you to Rebecca as well as Jana, and also our audience for joining us. Until next time, don't remember that if you or someone you know might be struggling with ASD, don't suffer in silence. Talk to a professional, reach out, and remember that asking for help is not a sign of weakness. So thank you so much, and we wish you a good day. Goodbye.
Yeah, thank you again. Bye.